This talk is about dementia, and I want to give a special thanks to Dr. Zoe Arvanatakis, who is an Alzheimer's expert here, who contributed some of the slides. Dementia is defined as a decline in cognition that is sufficient to interfere with daily life. We are going to learn about several disorders that are associated with a decline in cognitive skills. Depending on which area of the cortex the degenerative disorder or vascular disorder affects, and actually, in fact, we'll talk about an infectious disorder as well. Depending on which part of the cortex it affects will determine the type of symptoms that the patient initially presents with. Many of the dementing disorders will look similar, though, as the disease progresses into the moderate or severe stages. All of these diseases do require that the cognitive deficit causes a problem with activities of daily life. If the patient is only having mild symptoms of cognitive deficits, they would not meet the criteria for dementia. There is a spectrum of cognitive function. Many individuals will live into old age with normal cognitive functions. However, there are many individuals in the population that will develop mild changes, and some go on to develop a dementia. Mild changes are defined as mild cognitive impairment, and those are individuals who have cognitive impairment but do not yet meet criteria for dementia. Frequently, it is because the cognitive impairment is not interfering with activities of daily life. Mild cognitive impairment can be thought of as a prodrome of Alzheimer's disease, as a high percentage of the individuals diagnosed with mild cognitive impairment will go on to meet criteria for Alzheimer's. Alzheimer's is a disease that is more prevalent as individuals are older, especially over the age of 65. And as you can see, the population in the U.S. is increasingly becoming more aged. For this reason, if you have not personally been touched by Alzheimer's disease in your family, it is very likely that as you get older, you will be touched by this disease personally. And for this reason, it has been invested in by the National Institutes of Health with a lot of research dollars in order to try to find ways to stop disease progression or to mitigate symptoms. Let's talk more about Alzheimer's disease. This is a common and chronic disease, usually of older individuals, and it is the most common cause of dementia. Alzheimer's has a slow onset and a gradual progression of memory deficits and other cognitive domains that become impaired. Manifestations of Alzheimer's disease include cognitive impairment, including memory, language, attention, and visual spatial function. Behavioral disturbances can happen as well. Some patients will have psychotic symptoms, including hallucinations and delusions, whereas other patients will have agitation or aggression. Some patients will have all of the above. Affective disturbances such as depression are seen in many of these patients, and some of them will have mild motor impairment such as Parkinsonism or myoclonus. The Parkinsonism seen associated with Alzheimer's disease is much more mild than that seen with Lewy body disease or with Parkinson's disease dementia. However, you can see a very small amount of stiffness in these individuals. Alzheimer's patients, like other patients with dementia, do have weight loss as well. The clinical approach is that there is no single test to diagnose Alzheimer's disease. A combination of a detailed history, examination, cognitive examination with neuropsychological testing, and other additional tests are used to make a diagnosis. When you're taking a history in a patient who has cognitive decline, you frequently will use other sources than the patient to collect that information. Most of my patients in the clinic will arrive with a spouse or a child, and I take a history as sort of a team approach, asking everyone in the room these questions. There is frequently a discrepancy between the patient and the patient's family member or caregiver who accompanies the patient, so it is important to obtain information from both. You will want, when you're taking a history, to understand how many years of education your patient has had and what was their prior occupation. Many of the individuals who develop Alzheimer's disease are retired. However, some of them may still be working and the symptoms may be interfering with their activities at work. You want to ask patients about their recollection of recent events, their ability to repeat questions, misplace important items, or get lost. And these will all give you an idea of how their memory is functioning. Many patients with Alzheimer's will have word-finding difficulties and have great difficulties with functional capacities such as finances. Many individuals in the age group that have Alzheimer's disease are still of the generation where they balance their checkbook. And frequently one of the comments I hear in the clinic is that they're having difficulties with this task. Grocery shopping can be a problem, arranging travel, even travel domestically, taking their medications or remembering their medications, and general hygiene can all become an issue. These patients will have a wide array of behavioral disturbances such as dysphoria, crying, suicidal ideation, aggression, or sleep disorder. In fact, many of the patients that we see in the clinic will have what seems to be a personality change when they develop dementia. Patients who are very social can become socially withdrawn, and patients who are less social can become kind of agitated and irritable. You may not always get a history of a personality change, but it is very commonly heard in the clinic. The disease is progressive, so you would like to get a history that the symptoms have been progressive as well. Sometimes there is an abrupt recognition by the family or a true abrupt onset, and you need to determine that because it may mean you're dealing with something other than Alzheimer's disease. Many patients with Alzheimer's disease will retain a lot of their social skills, even into moderate stages of the disease. So if you have family members that don't frequently interact with the patient, they may not recognize there is a problem until things have advanced. There are several other conditions that can be associated with dementia, such as stroke, falling, and medications that have the potential to cause cognitive impairment. So you're essentially asking about other symptoms that could signify you're not dealing with Alzheimer's, and it's important to do this when you take the history. When we examine a patient for dementia, we are going to really focus on the mental status and do a mental status exam, which I'll remind you of in the next slide. The neurological exam, you will do a complete exam. However, you will be looking for focal findings, such as problems with the long tracts that would suggest the patient's had a vascular problem, or Parkinsonian symptoms that would suggest you're maybe dealing with another disorder. Other focal findings will direct you to more rare causes of dementia as well. As you recall, the mental state exam is part of what we do to assess cognitive function. This particular mental state exam was developed to look for signs of Alzheimer's disease. It does focus on several cognitive domains: orientation, short-term memory, attention and calculation, and language. It also allows us to look at visual spatial function by drawing the bisecting pentagons. If patients score less than 24 on this test, we can be certain that they have cognitive impairment that is likely going to rise to the level of dementia. For patients who score less than 27, I would frequently refer them for additional neuropsychological testing. Patients who have a lower level of education may have a little bit more forgiveness if their score is lower, or in patients who have other medical problems, you may take those into account as you're scoring the exam, such as difficulty with their vision or inability to write. Alzheimer's disease has specific pathology, both macroscopic and microscopic. In general, patients with Alzheimer's disease will develop cortical atrophy or volume loss over time. And this tends to really be seen in the medial temporal lobes and association cortices. The patients will have smaller gyri than expected and enlarged sulci. The ventricles also appear to be larger because you're losing cortical volume, and so these patients will frequently be termed to have ventriculomegaly. Many patients will also have the co-occurrence of atherosclerotic disease evidenced by small white matter changes on their images. They can have prior infarcts or strokes, and some of them will have small amounts of hemorrhage. And let me just clarify, that's hemorrhage into the small blood vessels that wouldn't appear as a large hemorrhage on exam. This is a gross appearance of a patient with Alzheimer's disease on the left compared to a normal individual on the right. And what you can see is there's a lot more space around the brain than you would expect. So on the right, you can see that things are kind of tightly packed, whereas on the left, we have a lot more space in all of these areas. And this is typical of Alzheimer's disease. There's especially atrophy in the hippocampus of Alzheimer's disease, and this makes sense when you localize because many of these patients have memory disorders as their first symptom. In Alzheimer's disease, there is a loss of neurons, which is area and cell specific. The loss of neurons occurs in the basal forebrain and includes the nucleus basalis. You usually will get more than 75% neuronal loss. And this area is going to impact the cholinergic system if you lose neurons. So you're going to have decreased levels of acetylcholine. We use this in order to help us treat the disease. And you'll learn about this in neuropharmacology. Entorhinal cortex and neocortex neurons are also lost. And these are large pyramidal glutamatergic neurons. In the hippocampus, you lose neurons in locations of CA1 and CA2, and these are also glutamatergic neurons. Inner neurons in the neocortex, and finally neurons in the brainstem, specifically in the locus coeruleus and the raphe. Microscopically, there are two key findings in Alzheimer's disease. The first is the neuritic or senile plaque. These plaques contain extracellular accumulation of proteins, including amyloid. The second key finding microscopically are neurofibrillary tangles, and these include intracellular accumulation of hyperphosphorylated tau. This is a picture of what the neuritic plaque looks like, and the plaque is kind of located in the middle. These plaques, if seen on past section, are specific to Alzheimer's disease, and it is very likely you will encounter this in the future. Amyloid beta peptides are important in Alzheimer's disease, and they are derived from the amyloid precursor protein, or APP. The APP gene is located on chromosome 21, and it codes for 3 proteases. There's secretase alpha, beta, or gamma, which are all involved in cleavage of APP, the protein. This leads to several A-beta peptides of various lengths. There needs to be a balance between the various forms of A-beta, otherwise there's going to be a problem within the central nervous system. The generation of A-beta depends on the cleavage of APP. If normal cleavage occurs with alpha secretase first, then A-beta cannot be produced, as this cleavage site is located between the cleavage sites for beta and gamma secretases. If abnormal cleavage occurs with both beta and gamma secretases first, then you will generate A-beta. This is a picture showing this, with the picture in A of the amyloid precursor protein. In the middle and the top of B, we see normal cleavage with the secretases. Down below, we have abnormal cleavage. And this abnormal cleavage is going to lead to aggregation of beta amyloid 142 and other proteins. This abnormal protein will aggregate or clump within the neuritic plaques that we see in pathology. So although we classically talk about beta amyloid being within these plaques, there are several other proteins that we will see, including tau, ApoE, ubiquitin, and presenilin. We're going to come back to some of these later in the slide deck. Neurofibrillary tangles are the second microscopic finding of Alzheimer's disease. The main component is phosphorylated tau. Tau is a normal cytoskeletal component that helps bind and form microtubules. It's critical for normal functioning of the axonal transport system of the neuron. The tau gene is located on chromosome 17. It is important to remember that the number of tangles, neurofibrillary tangles, will correlate with the severity of the dementia. As far as risk factors for Alzheimer's disease, I do want to comment on ApoE. ApoE is a glycoprotein that is a carrier of cholesterol. Within ApoE, there are several polymorphisms that can be associated with Alzheimer's disease. A polymorphism at ApoE2 is associated with a lower risk of developing Alzheimer's disease. A polymorphism at ApoE4 will lead to a higher risk of sporadic Alzheimer's disease. And if you carry 2 alleles with the polymorphism at ApoE4, your risk is even higher. You can have isolated gene mutations in APP and 2 other genes, presenilin 1 and 2. If this occurs, it is likely you will develop Alzheimer's disease, and these 3 genes will account for many of the familial forms. These patients tend to have an earlier onset than those with classic sporadic disease. Patients with Down syndrome are very likely to develop Alzheimer's disease, and the reason why is because these individuals have 3 copies of chromosome 21. Because of this, they have 3 copies of the APP gene as it sits on chromosome 21, and they will overproduce this protein. Almost all individuals with Down syndrome will develop neuropathological manifestations of Alzheimer's disease by age 30 or 40. And often the caregiver will notice a decline in cognitive function that is superimposed on their baseline intellectual disability. This is an important point to remember as it frequently shows up on step 1. For all of you who are worried that you will eventually, or your family member will develop Alzheimer's disease, there are several modifiable risk factors that could be considered. A higher level of education appears to be protective against Alzheimer's disease. A lower level of participation in cognitive stimulating activities increases the risk you will develop the disease. So frequently I encourage my patients to socialize and to engage in activities that stimulate the mind after retirement. Patients who are having strokes, even small infarcts, are at higher risk of developing the disease. So we ask to control several cardiovascular factors, including diabetes, homocysteine levels, smoking, and alcohol intake, and we ask our primary care doctors to help us do this with our patients. Patients who have untreated depression or who have a neurotic personality are more likely to develop Alzheimer's disease. You may argue that you cannot change baseline personality, but you can change at least the depressive symptoms. Patients who have a history of head injury, especially several head injuries, with loss of consciousness, are much more likely to develop Alzheimer's disease. So this is one of those diseases that we will see in patients who have careers that involve being hit in the head, such as boxing. And finally, dietary factors are important as well. There are likely many other modifiable risk factors that we'll learn about as you guys are progressing through your training. Let's move into a couple of other causes of dementia, and you'll need to be able to distinguish between Alzheimer's disease and these. Lewy body dementia I've already discussed in the movement disorder talk, but let's remind ourselves of the clinical features. It is a disorder with progressive cognitive decline, but these patients will also have, on top of that, fluctuating cognition and variations in alertness. These patients will have recurrent visual hallucinations and motor features of Parkinsonism. Cognitive decline tends to start right away at the same time as the movement disorder, and pathologically we see Lewy bodies that accumulate within the cortex. Another dementia that we need to learn about is frontotemporal dementia. This is also called PIC disease. In this disease, you have early changes in personality and behavior. Sometimes this is the first manifestation of disease, and for this reason, there can be a delay in diagnosis. These patients will develop a variety of other cognitive abnormalities, including aphasia and dementia, in addition to the dementia. The aphasia makes sense given that this particular disease preferentially injures neurons in the frontal and temporal lobes. And as we know, that is the location of the language pathway with Broca's and Wernicke's. Some of these patients will develop mild Parkinsonism or other movement disorders, and many of them will have upper motor neuron signs. Some patients, in fact, will also have lower motor neuron signs. However, knowing what we know about the pathology, we really would expect that we're hitting the corticospinal tracts in the frontal lobe. Pathologically, these patients have frontotemporal lobe degeneration, and they can have inclusions of hyperphosphorylated tau, or what we call PIX bodies. These contain ubiquitinated TDP-43. This picture here is a PIC body, and you may see this again. As you've noticed in multiple diseases that we've talked about already, many of these diseases are associated with inclusions within the cortex. It's almost the brain's way of hiding away those abnormal proteins and trying to dispose of them. Unfortunately, in all of these diseases, it appears that some threshold is reached and the brain can no longer clear these abnormal proteins. And when this occurs, you develop aggregation and additional clinical features from the loss of neurons. Vascular dementia is a very common cause of dementia and can even be superimposed on Alzheimer's disease. This occurs when there are multiple arterial infarcts or chronic ischemia. It can occur even with damage to the small vessels. There is a stepwise decline in cognitive ability that correlates with each additional vascular injury. These patients tend to develop memory impairment later in the disease and other cortical signs earlier, depending on where the vascular injury has occurred. Neuroimaging will show multiple cortical or subcortical infarcts. So as you can see on these images, which are FLAIR images, we can see these white matter abnormalities or injuries all throughout the cortex. And in fact, as you continue to go down, you can see them as we hit the brainstem regions and the temporal lobes. You can imagine in patients who have multiple injuries to the small vessels and locations in the white matter that you could have patients presenting with long tract signs in addition to cortical signs and cognitive decline. Creutzfeldt-Jakob disease is a much more rare cause of dementia, and it is rapidly progressive. Individuals who develop Creutzfeldt-Jakob will frequently progress quickly over the course of months, usually less than years, to their death. This particular disease, in addition to being frequently seen with cognitive decline, will also be associated with myoclonus. And again, we learned about myoclonus in the movement talk. This type of myoclonus is a little different in that it's associated with startle. The way we test this in patients is that I'll frequently carry a very large textbook into the exam room with me, and when the patient's not aware, I'll drop it on the floor, startling them, and you will see the emergence of myoclonus. There are probably other ways to do this as well, seeing as I'm not sure people actually buy textbooks anymore. Creutzfeldt-Jakob occurs from an abnormal infectious protein called the prion. This concept is a newer concept, and actually the individual who discovered the prion protein won the Nobel Prize for it. This particular protein is a protein that is natively occurring in your cells. But what happens is that the prion changes conformationally and is an infectious particle made up of misfolded protein. The prion, once it becomes infectious, will spread throughout the brain, wreaking havoc and killing neurons. Patients with Creutzfeldt-Jakob will have characteristic findings on their EEG, specifically periodic sharp waves. We will learn more about EEG tests next week when we go into the epilepsy case. Traditionally, we would test for a particular protein in the spinal fluid called the 1433 protein that was present and elevated in patients with Creutzfeldt-Jakob disease. However, we are no longer doing this as frequently because we can make a diagnosis using neuroimaging. What we see on neuroimaging is cortical ribboning. It almost looks like somebody has placed a ribbon on the outside of the cortex, and it will appear bright. This is very helpful in making the diagnosis of Creutzfeldt-Jakob. Pathologically, we have spongiform changes within the cortex, which can be seen here, where the cortex starts to look like a sponge due to numerous small cyst-like spaces that will injure and subsequently increase the rate of neuronal death. This is the last slide for the dementia talk. We will have questions to help you master this material, and it will also be included in our activities for the Parkinson's disease case.